See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association and hosted by nurse economist and health tech specialist Shauna Butler.
Hey, See You Now listeners, Shauna Butler here. As we roll into September, we're adding our support to National Suicide Prevention Month by having another listen to our Sending Out an S.O.S. episode. We're taking this moment to raise awareness of this stigmatized and often taboo topic, to shift public perception, spread hope, and share vital information about suicide prevention. Observed annually on September 10th, World Suicide Prevention Day demonstrates a global commitment to suicide prevention. The theme for 2022 is Creating Hope Through Action, which reflects the need to act now to address this urgent public health issue, advocate for better mental health care, including effective crisis response systems, and spread awareness that 988 is now the new nationwide number to contact for mental health, substance use, and suicide crisis. A simple, easy to remember way for people to get help and stay healthy. And now, on with the show.
This was an issue that predated the pandemic.
The stresses of being a healer before pandemic were very, very significant.
Burnout, depression, anxiety, and even suicide are well known and actually documented occupational hazards of working in healthcare.
The suicide rate for people who are physicians dramatically higher than the suicide rate among the general population.
And nurses have an even higher rate of suicide.
In addition to that, something that the industry had acknowledged but had not been widely reported on is that there's a 200% chance of medical error when the healthcare workforce is burnt out.
The effect of the last year and a half on our frontline healthcare workers has been incredibly dramatic. The burdens of COVID on people's health, on people's well-being, happiness, anxiety, the worries they have about their own health and the health of people they love, the economic anxieties that they're facing in their job or maybe in a business they own, compounding, has just really, really been difficult. And it's touched everyone.
My sister was Lorna Breen. In this experience of telling her story, we've met the most brave warriors, the suicide survivors of healthcare providers.
I wish we were looking at COVID in the rearview mirror. We're not. We need our healers to be healthy, not only because we've already asked so much of them, but the months ahead, we're going to ask a lot more of them.
We need to take a collective stand to show that we are here for our healthcare workers who are here for us.
Healthcare professionals have long experienced high levels of stress, exhaustion, and burnout. And the COVID-19 pandemic has only exacerbated this existing problem, made it more visible, and escalated the urgency to address it. While helping their patients fight for their lives, many healthcare professionals are coping with their own trauma of losing patients and colleagues in fear for their own health and safety. And the details of just how difficult it is are revealed in the stories of many healthcare professionals. Each one is sobering, each one significant, and each one has the power to bring us to our knees. One of those is the story of emergency physician Dr. Lorna Breen, whose commitment to her colleagues will be memorialized in U.S. federal legislation. The Dr. Lorna Breen Healthcare Provider Protection Act was written to promote and protect the mental health, well-being, and fitness of our healthcare workforce. Senator Tim Kaine is the bill's co-sponsor.
Here's what the bill would do. It established grants for healthcare professionals or trainees in strategies to deal with mental health, substance use disorders, thoughts of suicide. It requires the identification and dissemination of the best practices for preventing burnout, stress, suicide among all healthcare professionals, including trainees, med students, nursing students, others at the beginning of their career. It establishes a national education and awareness initiative to encourage healthcare providers to seek the help that they need and ensure that they're not burdened or punished if they do so. We establish grants to healthcare entities that have done novel things that seem to be working so we can have them do more, learn from them, and hopefully scale them up around the country. And finally, the bill promotes a review related to improving the mental health of healthcare professionals and their resiliency, including how the COVID-19 pandemic has affected our healers.
In this episode, we learn about the significance of enacting first ever national legislation directed at protecting the nation's healthcare workforce. We meet the co-sponsor, inspiration, and supporters of this legislation and learn what actions are being taken and what's working to protect and care for those who care for us.
I'm Tim Kaine, junior senator from Virginia and proud co-sponsor of the Lorna Breen Healthcare Provider Protection Act, which was an idea that was very much birthed because of my being a good listener to two amazing leaders, Corey and Jennifer Feist, and together with my staff member, Katie Wright, we've put something together that's very bipartisan, that's already doing good and can do more good.
My name is Corey Feist. I'm the president and co-founder of the Dr. Lorna Breen Heroes Foundation. After spending a career in healthcare of over 20 years, I have now stepped full-time into this role. My wife, Jennifer, and I co-founded the Dr. Lorna Breen Heroes Foundation in June of 2020 after my sister-in-law, Dr. Lorna Breen, died by suicide at the beginning of the pandemic. I tell Lorna's story a lot in talks that I'm giving across the country right now. And I think what's really important about the story is the themes that of her story really resonate with so many, whether they're nurses or doctors. And those are those themes that need to be attended to. I'll take you back to March 10th, 2020. It was the last day that we skied together in Big Sky, Montana. Now, Lorna was a passionate snowboarder, and it was a really special time for our family. So when she arrived the week of March 10th, the pandemic was really just starting in many places, but really she was feeling it in New York, and she was double boarded in emergency medicine and internal medicine. And she always wanted to be an emergency medicine physician in New York. So when she arrived, she was talking about how they were right in the middle of implementing an electronic medical record, and there was this pandemic.
And you'll remember in the early days of the pandemic, as we were trying to figure out what it was, it hit New York like a tidal wave. And the hospitals in New York became filled with patients. The rooms were overflowing. Patients were in the halls. Patients were outside. Patients were jamming waiting rooms. And the physicians and healthcare workers were working around the clock. The guidance was sort of unclear at the beginning. Exactly what are the symptoms? Exactly how do you deal with COVID? What's the best practice? Hospitals didn't have personal protective equipment. You might not have a mask to wear, or if you did, you'd have to pin it up with a thumbtack on a bulletin board at the hospital and reuse the same mask the next day and the day after that and the day after that. So added to a profession that already is subject to significant anxieties, COVID just put so much more of a burden on these healers.
What I observed with Lorna was that even though she had the week off, she was on the phone increasingly throughout the week, and then left our trip to go back to New York. Shortly after returning to work, she contracted the virus. And because she was sick, but not sick enough to be admitted, she convalesced at home. It was a very sick episode. She lost a bunch of weight. She wasn't sleeping. She was trying to work and cover the ED, but she felt this very, very intense need to take care of the workforce. And so her very first 24-hour period where she didn't have a fever, she called and said, "Put me back on the schedule. I'm coming back to work." And that was April 1st. That first morning back, she contacted us and said to us, Everyone can tell I can't keep up at work, and this is going to impact my career.
She knew she was beset with stress and anxiety. She knew she needed help, but she was afraid to ask for it. She was afraid to ask for it because the medical profession still makes it hard to ask for it. You can get asked by a licensing board, have you ever been treated for mental illness? Have you ever sought treatment for depression? You can get asked for licensing or credentialing purposes those questions. And many in the medical profession, and surveys have shown this again and again, are reluctant to seek help or reluctant to tell others they need help because they're worried about their job.
She was scheduled for 10, 12-hour shifts in a row after spending basically a week and a half very sick with COVID. And it wasn't a 12-hour shift. It was really a 15 or 16-hour shift because people weren't going home because there wasn't enough staff and there wasn't enough PPE. The other thing that she said to us that day, April 1st, was that what she observed was Armageddon. Not enough supplies, patients just dying in the waiting rooms, waiting to be seen. And so the volume of death and dying that she'd observed as a seasoned doctor was overwhelming.
I have had a number of sessions where I've talked to nurses and doctors and allied health professionals, and they've described what it is to deal with death at an unprecedented scale. And they tell the story, you know, I'm a physician, I'm a nurse, I'm used to a couple of deaths on my ward a week, but not 4 or 5 a day. I'm used to dealing with a dying patient and helping the patient's family come into the hospital room and helping create kind of a sacred space for family to spend their last moments with a loved one. But I'm not used to having to shut the family out because it's a communicable disease and holding up an iPad so that a person who's gasping out their last breath on a ventilator can say goodbye to family members with me as the mediator of that last discussion.
As those days progressed, you know, she basically was just trying to grind through, but it was an overwhelming experience for her, so much so that on April 9th, she called Jennifer and said she couldn't get out of her chair. So in an 8-day period, she went from being a highly functioning physician who was coming off of COVID, who observed this trauma and really ill-equipped to help. Now she is literally in the fetal position in her apartment saying, I can't get out of my chair.
The last professional article that she published was published just a couple of months before the start of COVID at the end of 2019. And the article that she published with some of her colleagues was how to deal with the phenomenon of burnout in emergency rooms. So she was aware of the challenges of the profession and aware of the mental anxieties that it put upon healers even before pandemic.
Jennifer said to her, well, okay, I get it. Get on a plane. And Lorna said, you don't understand. I can't get out of my chair. I think I'm going to die. And that's when we went, okay. So we had the phone number for a friend of hers from medical school who was in Connecticut. So her friend from Connecticut dropped her patient load and drove immediately into the city, found Lorna, threw some things in a bag, and drove her south on I-95. And she was picked up by another childhood friend in Philadelphia on the side of I-95 and continued to drive south all the time while Jennifer was driving north, and they rendezvoused outside of Baltimore. And Jennifer just turned the car right around and drove immediately to the University of Virginia Hospital, where she was admitted to the psych unit. What was incredible about that, on April 9th, she's saying, I can't get out of my chair. On April 11th, having been in the psych unit for less than 48 hours, she was telling us that she was going to lose her license to practice medicine and her career was over. And we were dumbfounded by that and said, you just need to focus on getting better. And she kept saying, no, you don't understand. My career's over. And she was discharged after spending about 10 days in the inpatient unit, and came home for a few days and died by suicide on April 26th, 2020. And we were just shocked, ill-equipped to respond, didn't really know what happened, but she was gone. We had at that point tons of press was coming at us, and so we agreed to go on the Today Show. We recorded it 48 hours after she died. But what happened on the other side of that publicity was really the catalyst for why we started the foundation, but it was overwhelming. The number of people that reached out who we did not know across the world, the stacks of letters that I have, it was unbelievable that everyone wanted to share not only their support, which was so welcome, but also their stories about how they had crammed down years of their own trauma, depression, mental health challenges, or just challenges on the job. And that's when we decided that we needed to step into this arena and just make an impact.
Lorna's brother-in-law, Corey Feist, and Senator Tim Kaine have shared Lorna's story hundreds of times in an effort to raise awareness and build support. But hearing it for the first, even second or third time, we are struck by the multiple dimensions of devastation and loss the pandemic has wrought. That our nurses continue to experience a disproportionately high rate of depression, anxiety, moral injury, feelings of hopelessness, and thoughts of suicide is no surprise to nurses and nurse researchers like Christopher Fries, for whom this legislation offers a most welcome and much needed intervention.
What I'm excited about with the Dr. Lorna Breen Protection Act is, to my mind, it's one of the first concerted efforts to better address the issue of clinician well-being launched by the U.S. government. I'm Christopher Fries. I'm the Elizabeth Tone Hosmer Professor of Nursing, Health Management and Policy at the University of Michigan at Ann Arbor. I have been an oncology nurse for 25 years, and my research is focused on two things. One is improving the quality of cancer care that patients receive. The second area of interest is understanding the work environment of nurses and how we can make it better, how we can make it safer, and why better, safer nurse work environments are good things for patients. A very specific area of work that we've done is surveying nurses on their working conditions to look for things like burnout and moral injury, trying to understand the factors that contribute to nursing job satisfaction and intention to leave their workplace. And more recently, we published a paper in JAMA Psychiatry that unfortunately showed very high rates of death by suicide among registered nurses across the United States. So we're trying to understand those factors and what we can actually do to improve the situation. First of all, deaths by suicide were on the rise, and they were on the rise before the pandemic. So obviously, nurses have had a lot of stress during the pandemic, but what we saw is that basically it was a steep line up, and our data went to 2017, and what we saw is that in 2017, we had an all-time high of deaths by suicide among nurses with a pretty much of a straight line up. So that was number one. The number two thing that we found is, deaths by suicide are more likely among males. What we saw in these data, of course, nursing in the U.S. is primarily a female population. We saw among females that nurses had higher rates of suicide than females in the general population. And then we also saw that female nurses had higher rates of suicide, deaths by suicide, than physicians. There's been a lot of concern about physicians. There's been less work done on nurses. And what we found, unfortunately, is that nurses had higher rates than both the general population and physicians. Our studies, as well as a whole list of studies, have shown that healthcare workers face a higher risk of mental health conditions that are specific to their working environments. So that's something new and different, that simply being in a job category of taking care of patients puts you at higher risk for mental health conditions, number one. Number two, we know it's really hard for healthcare providers to take the pause, to recognize that they need help and possibly seek help by a peer. So we need different strategies to make healthcare providers feel comfortable in recognizing the challenge that they face and getting them very specific support that they need. And we have some models to do that, but we haven't had the funding to really scale those up. And then finally, I'm excited that this will hopefully open up a national conversation about this, that we can realize that a mental health condition is just like diabetes. We have good and effective treatments. The key is to recognize that someone needs those effective treatments and connect them to an expert who can help them. And I'm really excited that the bill is really going to help us open up that conversation and help healthcare providers, physicians, nurses, and others see that there's no stigma here, there's no shame. We want to take care of you so that you can take care of our loved ones, right? That's the key. And so that's really exciting to me, that we have that greater recognition of a conversation about this, and then we have money to really help us develop programs and services that will help specifically healthcare workers, because their patterns of mental health and death by suicide look different than the general population. So we need to account for that.
That stigma and concern about professional penalties that Chris speaks about is profound among healthcare professionals, especially when it comes to seeking help for workplace stress and mental health conditions. And that might come as a surprise to those who are not in the profession. But being a healthcare professional, as rewarding and purposeful as it can be, also comes with its own pressures. Pressures that society may unknowingly be compounding with the words used to express appreciation. As Senator Kane shares,
it was shocking to me, but then once I heard it, as Corey and Jennifer talked about Lorna, and they said, what was she most worried about in this period? It even more than I'm going to get sick, she was worried about, if I need help, I'm going to lose my job. I may be asked a question about seeking mental health treatment that could affect licensure or credentialing at a facility or professional certifications. Or how will I seem to my colleagues? They're having to work double duty just like I am. If I need help and back away, then they'll have to work triple duty. And so there was a feeling of kind of guilt about that. And that's because of a society broadly, but particularly in the medical field, that doesn't make it easy for people to feel like they can seek help. And I worry that, frankly, those of us who aren't healthcare professionals make it worse. When we say people are heroes, heroes are often put on pedestals, and you can't live on a pedestal. And so, I think healer is a better word than hero, and it doesn't necessarily convey I got to be like a Marvel, comic superhero or something. And so I even in the way we try to express thanks or appreciation, we may do it in an awkward way that increases the pressure on people and makes them feel less likely to be able to seek help. And so there's the real barriers, those places where there are actual, in law or in professional practice, real obstacles and barriers to seeking help. But then there's also the perception that people have. And sometimes there's states that actually have pretty good policies, and yet they're not well communicated. So the health professionals in those states still feel like, well, I can't seek help, or if I do, I'm going to run some professional risk. So there's an education and communication part of this that is, I think, one of the most important parts of what we can do to change the trajectory.
Corey?
Two things come to mind there. First of all, when we started doing this work and people wanted to talk to us, and I was thinking about what could the Lorna Breen Foundation do? The first thing was awareness, because I was doing all these media appearances and talking about this. And I never would have thought that would have been enough, to be honest. But what I quickly came to learn was there's so much in Lorna's story that resonated with people. That when I, in speaking with a mental health professional who did a lot of work with post 9/11 first responders, she shared with me, she said, when the unspeakable happens to you and you speak of it, it gives others permission to speak too. And that was exactly the experience that we had. And so the more we spoke about it, the more we heard from people saying, thank you. These were people that found us on our website, drlornabreen.org, and they were just finding us and they were saying things to us like, this story saved my life. I saw myself in Lorna's story and I did something. I made a change. Or I saw myself in Lorna's story and my colleagues in Lorna's story. So we made a pact that every single day at this time, we were going to check in with each other. Because one of the first messages that we had, if you think someone's in trouble, don't wait to for another day. Reach out and check in on them. Check in on yourself and check in on them. So telling this story has had an incredible impact for the good. Speaking with doctors and nurses all the time, they've seen what Lorna saw now every single day for years. The second thing I would just say is, for me on a very personal level, seeing the response has been very therapeutic for me, and talking about this has been very therapeutic for me. Is one of the ways that I have been able to manage my grief, frankly, and process my grief.
Chris, and legislation is great. We've seen the Americans with Disabilities Act, the Affordable Care Act, Medicaid legislation, HIPAA, COBRA, where these have enormous impacts that ripple through. But legislation is slow. What do you see is the most critical intervention? What needs to happen now when it comes to the mental fitness amongst our peers?
Yeah, so we'll say, the legislation is essential, and it's important for messaging, it's important for resources, it's important for continuing this conversation, and so it's in my view, it's vital legislation that needs to move forward. But there are things that we can be doing right now in our local communities and at our systems. And so one of the things that I talk frequently with healthcare executives about, and it's not just hospitals, it's really across our sectors. So school nurses, community settings where a lot of care is delivered, EMS, vital frontline folks, skilled nursing, et cetera. So what we want folks to know is that they need to have systems in place to make employees, healthcare workers, aware that this is an issue, number one. Number two, as I said, it's just like diabetes. If we can get on the problem, the sooner we get on the problem, the sooner we can get you well and safe and healthy. And making sure that they have access to resources that are confidential, that don't put their workplace in jeopardy. One thing we often hear is people are afraid to come forward because they're afraid that they'll lose their license, that they won't be able to work. And so bosses really need to come to that level of compassion and empathy to say, this is something that we want to work with you on. We want to keep you healthy and safe. And so here are some resources that we have in our local community where you can seek care, seek assessment, seek referral in a confidential space, hopefully covered by their employer to the degree it can, that makes it easy for them to access and doesn't put any kind of penalty in place in terms of their job. I think the other thing that I'm really strongly recommending to healthcare leaders is take a very deep look around your work environments that you have for your healthcare workers, and what can you be doing now, today? What's the low-hanging fruit to reduce burden in the clinical environment that gets in the way of taking care of patients in the way that we would want to take care of? We're starting to hear more about what we call moral injury, sort of beyond burnout, this disconnect between what we want to do for patients and what we can actually deliver. And I think executives who can pay attention to that can seek the causes of those injuries and can hopefully improve things like documentation, busy work, getting supplemental staffing around clinicians so that they can really focus on their role in the healthcare system. Those are pieces that I think will lower the burdens on healthcare workers, allow them to give better care to patients, help them feel better about the work that they do. And I think that'll lead to overall lower mental health conditions and really flares, if you will, of the problem. We can kind of get the workplace a little bit more stabilized. I think that's going to be good for healthcare workers in the long run.
Yeah. So Corey, you are hearing stories from so many people from every position in our healthcare ecosystem. In hearing those stories, can you give some other examples of where you're seeing solutions? What are some things that people are actively doing at this moment. What are you seeing working?
Absolutely. We launched an initiative with a number of partners, American Nursing Foundation, National Black Nurses Association, Philippine Nurses Association, the American Hospital Association, American Medical Association, among others. We launched this initiative called All-In Wellbeing First for Healthcare. There are two goals in that, but the first goal is to advance solutions. So we have now over 300 members, allinforwellbeing.org, but what we've been able to do in that is get people in a room, break down silos, and start sharing solutions. So there are a number of solutions that we've heard about. I'll articulate 5 for you. First of all, recognizing that these are not normal times, non-normal times, and organizations need to adjust expectations, whether those expectations are on crisis documentation or around quality and patient experience goals. But just we have to recognize that staffing levels are low, the workforce is burned out, traumatized. This is not business as usual. So that's number one. Number two, I have been a long-standing lean management practitioner, which looks at value as defined by the customer. So in healthcare, we've designed everything around the patient experience. What we need to do is we need to design it around the team member experience, the nurse experience, the doctor experience, the tech experience, the pharmacist experience, and think about them as the customer, and then get rid of the things that are non-value added. I'll give you two examples that organizations are working on right now. The first is documentation and really time in the electronic medical record. I recently came across a piece of data that said that nurses spend half their time documenting. Doctors spend 60% of their time to 70% of their time documenting. So looking at getting rid of the administrative burden. And so we've seen hospitals and health systems double down on the electronic medical record and bring in virtual scribes or in-person scribes, or looking at just the levels of documentation that are needed on anything. We've also seen organizations get, I would say, radical about staffing. So they're bringing in people, and that can help with the administrative burden. They're bringing in retired nurse or retired physicians. Help us with this administrative burden so we can get the clinicians working on clinician work. The fourth thing that organizations are doing is they are identifying and designating a well-being executive. That is someone, and I use the term executive because it connotes authority. It has to be someone with authority over not just the therapeutic interventions that support our workforce, but also operational changes. So when someone on the front line says we need to change X, Y, or Z because it's burning us out, that chief of well-being, whether that has the title chief well-being officer, or whether it's the COO of a health system or chief nursing officer or chief executive officer, that person has to have that authority to say, yes, go make that change. And then finally, organizations are going beyond what I would say are traditional EAP services. So peer support seems to be one of the things that the entire workforce is really thriving from, nurses and physicians. I'm going to give you a piece of data from doctors. When the American Medical Association last year did its Coping with COVID-19 survey, which was of the entire workforce, I remember from that data that the number one thing that doctors wanted was a peer support program over anything else. Nurses were much more willing or accepting of going to formal mental health treatment when they needed it. But when you think about Lorna's story and impact on licensure, you can kind of understand that for nurses in 22 states and doctors in many, many more states than that, they're concerned about the impact of getting formal mental health treatment on their ability to earn a living. And so these peer support programs, whether those be nurses talking to nurses or doctors talking to doctors, they are very, very effective. And I was just on a call with a large health system in the Northeast, and they've seen great progress in their nursing and their physician workforce in peer support. So those would be the 5, recognizing these are non-normal times, getting rid of the administrative burden, doing radical things to shore up staffing, designating a head of well-being, and then finally going beyond the traditional EAP to really recognize the resources. You'll note in that list that 4 of the 5 are about the environment that the workforce is working in. Only 1 is really about taking care of the canary in the coal mine. And I think that's very important because I've seen and I've heard from so many across the workforce this year, this isn't my problem to solve. And so we need to do both organizational and operational redesign, and we need to take care of the therapeutic needs of our workforce right now.
Senator Kaine, what are your thoughts on this question about what needs to happen now?
It is maybe somewhat easier to raise your hand and say, I need help. I do think we even need a culture where you don't have to raise your hand, particularly after an extreme event. I'm going to give you an analogy. My oldest son was a Marine infantry commander. He spent 8 years on active duty, and he's a reservist now who works at Customs and Border Patrol. But he had 2 deployments during his tenure with the Marines. After the first deployment, the SOP was you come back from a deployment and, somebody who's like a battalion level officer says, you've been on a deployment. If any of you need mental health assistance, here's what to do. Okay, he did his next deployment a couple of years later, and the SOP had changed. Now, okay, you're back from a deployment. All of you are going to have a meeting with a mental health professional to just talk about the experience of your deployment. Nobody had to raise their hand. You're all going to have one. And then that professional could determine, along with the Marine, okay, do I want more than one conversation? Are there other things that I need? But it started with you had to raise your hand, and then the second deployment, you didn't have to raise your hand anymore. And particularly, and they did that after deployments. That wasn't just the every year thing, but it strikes me that after a pandemic, worst health, public health crisis in the last 100 years, there should be more affirmative solicitation of a workforce. Hey, here are resources we have, and I can see how hard you've been working. I can see how many extra shifts you pulled. I can see the number of people that have passed on your unit compared to whatever the historical norm was. You ought to sit down and talk to this person and just, air whatever feelings you have, and everybody, and I'm doing that, and everybody should do that, So let's not force people to just raise their hands. Let's make it easy for them to, but I don't think we should necessarily wait for that in times of extremis.
There is a nurse at University of Virginia. His name is Jonathan Bartels. He is the creator of the pause, which is a ritual that many health systems perform after there's a loss of a patient, where it's just a moment to recognize the effort that was put in and the life that's been lost. One of the things that Jonathan says is that if you think you're going to come into this profession and not feel the emotional toll, he said, it's like thinking that you're going to go into the ocean and not get wet. He said, we are going to get wet. The question is how are we going to dry off? How do we program in to say, we know that this work is hard and we care about our workforce and we care about our health systems and the safety of the people that we're treating. So let's program that in to make sure on the front end of this, let's preserve your health and your well-being. So in this legislation, where do you see the legislation having the impact where there's a really powerful paradigm shift that says we're not waiting and asking you to self-identify, and we are putting systems in place to prevent that and to detect it at its earliest possible moment and provide care that is free of stigma or free of a professional or an economic risk?
I think the key is going to be you do the research into best practices and polling, and then you communicate best practices. For me, what I like the best is funding, grant funding for best practices in both healthcare settings, but also in the schools that are educating our healers to create this culture change. There's a good bit of flexibility in how these dollars are used, and you all have dealt with grants before. I mean, the interesting thing, there's a grant opportunity, and you can be as creative as you want in coming up with the right strategy that's right for you. And then sometimes this is a problem at the federal level. We need to learn from the best practices and then replicate them, and not just say, hey, great job, shake your hand. Now the grant, the 3-year grant is over. I mean, this is always taking the wisdom from best practices and then really replicating them on a larger scale is going to be the challenge. We're going to have no shortage of really good ideas now that we're focusing on it. The challenge will be trying to replicate the successful ideas broadly, and that will be the culture changer that you ask about.
Chris, I've heard you say this before, and I've read it in many of the things that you have posted. And there's a lot of energy behind this. What's your recommendation about healthcare executives listening to nurses and, more importantly, acting on their concerns immediately?
Yeah, no, this is a passion of mine. And let me say that many of my friends and colleagues are executives and leaders, and I know it's incredibly difficult. One of the things I would say to them right now is to think about bifocal lenses. So a lot of our leaders are right now plugging holes in their staffing to meet the need today, tomorrow, addressing urgent crises, and that's essential. Of course, we need that. But I want them to come up a little bit and look at the bigger picture and see what their teams are struggling with, and not necessarily rush to easy platitudes and solutions like pizza parties and Play-Doh and coloring books. Because what we're seeing increasingly is particularly nurses are turned off by that because it feels like a platitude. It feels like you're not listening. It feels like you're trying to put a Band-Aid on a problem. And I also don't think that healthcare workers expect their leaders to solve everything overnight. But what we're not having is an honest conversation between healthcare workers and leaders about the struggles that they're facing, and can we partner together to delineate and prioritize those issues and begin to work at them, as opposed to, I hear you, but there's nothing I can do, or that's too difficult, or we'll get to that at some other point. And that's hard. And, and I get it. And it's very, very difficult right now. And we're in a constrained set of resources. But I would argue that there are very strategic things that we can do with our power, with our prestige, with the little bit of money that we might have available that can make things better. But we haven't worked together to prioritize that and to think about it in a way that really puts healthcare workers at the center of this. Because a lot of corporate culture will say, if you don't care for your employees, they can't care for your customers, right? And we hear that often from the corporate side. But in healthcare, we have not paid sufficient attention to the health, well-being, and safety of healthcare workers. And I think this pandemic has taught us, if we don't create a safe, healthy environment for our healthcare workers, how on earth are they going to be in any capacity to deliver the kind of extraordinary care that they deliver? And what I fear is a lot of executives are chasing things that may not really help their workers or help their environment, because they haven't really had that engagement, a two-way engagement about what healthcare workers need. We get it. We know it's tough. We know money doesn't grow on trees, but we can be strategic about what we do invest in. And I feel like it hasn't been as strategic as it could or should be.
Corey, what are the metrics that organizations need to be collecting that are looking in real time at the well-being of their workforce?
That is an amazing question. And I want to hit on just why that's important, or where that data needs to be shared first. Every single board of directors of every single hospital in this country needs to add into their standard key performance indicators that they look at there to evaluate the overall health of their organization. It's usually focused on quality metrics and financial metrics. They need to add well-being metrics in. So here's a couple of them. Number one, every single electronic medical record that I know of has a regular, easy to extract report that shows efficiency and inefficiency in the electronic medical record. So we know that the number one cause of burnout continues to actually be these electronic medical records and this administrative burden. Just measuring how much time and demonstrating how much time your workforce, nurses, docs, the whole crew are working and how efficiently there is a really important metric, because I think it's a roadmap for every organization to say, oh, look, in this department, they're out of bounds with their peers. That's where we need to focus our intervention. Number two, data they're already sharing, which is quality data, but connecting the quality data to the burnout of the workforce. There are a number of employee burnout indices, and I would say that is something that needs to happen in the health systems right now. And then the last thing I would just say is looking at turnover data, but not just looking at that data and comparing it to, oh, look, we have a 20% nursing turnover rate, but the region is 21. So giving yourself a pat on the back and saying, wow, at least we're 1% better than average. That's not the conversation that needs to be happening around that data. What is driving, whether it's turnover, which is a lagging indicator, how can we retain the workforce? So those would be the list that I would just give you. And again, much of this data is already in the hands of the healthcare executives.
Chris, what do you see as the main challenges for nurses right now?
The biggest challenges that nurses in the U.S. face right now are twofold. One is, how can we have a more constructive conversation about the future of what we want nursing care in the United States to be? And that sounds like a lofty point, but what this pandemic has shown me is we have not had true innovation in nursing care delivery in over 2 decades. I'm going back to Beth Israel and Rush and different models of nursing care that we actually tested and we showed the positive outcomes for patients. And we haven't had that kind of innovation in quite some time. So I think, in DC, we often say never waste a crisis. Use a crisis to have a different kind of conversation and catalyze the changes that we think are needed. So I think we would all agree, nurses and executives would agree, the status quo is not serving anyone well, patients, clinicians, or systems. So let's have that conversation and envision how we might deliver nursing care across sectors, across settings, in a way that centers on patients, that delivers good outcomes and value for patients, and that also simultaneously restores joy in work. Wouldn't that be a fun conversation to have?
Yes, it definitely would be. And Corey, speaking to that element, the American Medical Association created their Joy of Medicine program.
Yep.
And many of these indicators have been included in that. I think joy is the ideal word, because it really hits on, you want to have that gleam in your eye, even when things are hard, even when things are distressing. There is a joy and a satisfaction and a meaning and a purpose that people feel safe. And I'm talking about your team members, the patients that you're taking care of. Maybe you can tie that into the Dr. Lorna Breen Foundation and how those things come together.
Absolutely. So the Joy in Medicine program has been around now for 3 or 4 years. The AMA created it, really focusing on how to eliminate burnout and increase the joy in the daily practice. And our website, allinforhealthcare.org, has tools for everyone in the healthcare community that tie to those 6 or 7 metrics in the Joy in Medicine program. Every single metric, except for one, is about operational and organizational redesign. There's only one, and it's about actually peer support. That is about the helping the workforce, I'll just say, thrive. But it absolutely recognizes and identifies hospitals and health systems across the country that are getting this better than others and are making an institutional commitment. If you go back to when the unspeakable happens to you and you speak of it, it gives others permission to speak to. The components around stigma are really pervasive around the culture of medicine, and working on having these conversations over and over and over again, I think is making a positive impact on the culture. Because in order to really recognize the operational changes, you've got to have a culture that's going to embrace any of this stuff.
And Corey, the Dr. Lorna Breen Healthcare Provider Protection Act. As we close, can you describe the major components of this legislation and your hopes and aspirations for what this is going to be able to do.
We are so incredibly fortunate to have a bipartisan, bicameral bill that is supporting the healthcare workforce at the federal level for the first time ever. And to have it named after Lorna is just incredible. So because the federal government felt so strongly about how great an idea this was, if you will, and this law, the programs actually under the Lorna Breen Act were funded in President Biden's first COVID relief package, the American Rescue Plan. So on January 20th, $103 million were allocated by the federal government to 46 different institutions in this country to support the well-being of the future and the current workforce, which is just, it's amazing to see that the money's out there even before the law got passed. So let me tell you the four components of the law. The first, it provides for programs to support, for health systems to support the well-being of the future workforce, those nursing students and those medical students and physician's assistant students, and really help them to recognize these issues and work towards solutions. So that's the first bucket. It's actually the predominant funding component. It includes programmatic funding for the current workforce, similar types of programmatic funding, again, going to hospitals and health systems. It provides for a nationwide awareness campaign on best practices and really recognizing and starting to elevate this conversation at a more consistent level. And then finally, it has a research study component, which is going to look at the root cause of the issues, many of which we know, and importantly, set a roadmap for future federal legislation to, again, support the well-being of the workforce.
Thank you for taking your personal experience and making it visible for everyone else. How can each of us and each of our systems and an ecosystem, how do we combine our forces to address this more rapidly and more successfully?
Absolutely. The 5 things that we talked about that organizations seem to be doing right now, that work needs to be done right now in every health system across the country. We can do a lot of this work kind of operationally. The culture work has to be done inside these hospitals. I can sit here and preach and scream it from the mountaintops, but I can't change the culture from within. And so everyone needs to be having these conversations within these hospitals about how do we create the culture where the joy can exist, a culture where we're taking care of each other, a culture that is receptive to operational changes that are, meant to benefit the workplace. That's the landscape that we need to have created for us right now. And we would really appreciate everyone leaning into that conversation with us. The last thing I would just say is please, follow us on social media. Please, follow our work. If organizations know about individuals and organizations that would consider helping to support financially our work, that's always helpful. Now that we're in this for the long term, but I would say first and foremost, every healthcare professional just needs to make sure right now that they're looking out for themselves and their colleagues and helping to create a culture in medicine where the workforce can thrive.
Senator Kane, some closing thoughts you'd like to share?
The big thing we often have in public life is with a title in front of our name, not because of who we are as individuals, but you have a title in front of your name, your presence with people adds something and makes them feel, well, maybe officialdom does know that I exist and officialdom does appreciate what I'm trying to do. And maybe there's a need for us to really, as we come up on a very tough 2-year anniversary, and it's not like a 2-year anniversary where it's in the rearview mirror. I mean, knowing that it's going to go on for a while, maybe there is a need for us to really flood the zone with thanks and compassion and listening. It's hard to take an experience of grief this deep and turn it into a public mission to help others. It's not a high percentage of people who do that. And that Corey and Jennifer have done it, and have done it in a way where the need was so great that they are really both on demand. That's a tribute to them, but it's also a tribute to how deep the need is, that once people know of Corey and Jennifer, they want to talk to them. So I want to thank them for taking a tough life experience, but saying that it's going to be to the extent any meaning can be made out of it, the only meaning that can be made out of it is what we can do to help others.
And Chris, other thoughts, messages you'd like to send to nurses and all our healthcare team members?
Wow. So, my message to the nation's nurses are a couple, and it's emotional for me because what I have seen and heard and what people have shared with me is unfathomable what some of our colleagues have faced. And so the first thing is thank you, and that I appreciate you. The second is to continue to tell your truth, and tell your truth to those in your local organizations, in your professional organizations, to your leaders about what you think will make the situation better and help. I think nursing solutions are the right way out of this crisis. And so I want to hear more from the front line as to what we can do differently, and we can amplify that, but we need to hear directly from you. And the third thing I would say is you are indeed not alone, and you have peers around you, and you have professional organizations who care about you. And increasingly, as we see with this legislation, more people are listening and learning. And so don't be afraid to reach out and let us know what you need, because I think you'll find, as opposed to prior days, I think people are listening more carefully and really want to help.
Christopher Fries is an oncology nurse and professor of nursing, health management, and policy at the University of Michigan in Ann Arbor, and a national research authority in understanding the work environment of nurses, how we can make those environments better and safer, and why safer nurse work environments are good for patients, communities, and health systems. A sincere thanks to our episode guests, Jennifer and Corey Feist, co-founders of the Dr. Lorna Breen Heroes Foundation, and Lorna's sister and brother-in-law, Senator Tim Kaine, proud co-sponsor of the Dr. Lorna Breen Healthcare Provider Protection Act. And special thanks to Katie Wright, Senior Health Policy Advisor to Senator Kaine, for listening to and advocating for nurses on the front lines of care, for her leadership in drafting this important legislation, and for helping to arrange our conversation with Senator Kaine. During the pandemic, the public has lauded every stripe of healthcare provider, often casting them as superheroes, brave women and men who take great risks and make great sacrifices in caring for patients. But for many, the grief, stress, and exhaustion have taken their toll. And we see that in the labor statistics, in the growing number of nursing vacancies, and in surveys indicating the alarming number of professionals who retired, left, or are planning to leave their clinical position, and even leave healthcare altogether. In one COVID-19 survey on mental health and wellness conducted by the American Nurses Foundation, more than half of critical care nurses surveyed said they were not emotionally healthy, and said they felt depressed, emotionally numb, weren't sleeping well, were overeating, were drinking more, and 6% said they felt suicidal. 75% of all nurses across all roles said they felt stressed. 1 in 10 said they felt worthless. And many that their organizations did not care about their well-being. As Chris references, in all care settings, we're seeing the stress, exhaustion, and burnout across the entire nursing profession, from school nurses to nurse managers and nurse leaders. And while these surveys aren't research studies, they are the pulse of the nation's nurses, a way for nurses to share what they're experiencing, let us know they're not okay, and point to the problems for all of us to act on. And when nurses say there are problems and they're not okay, they're not exaggerating. As Chris and Corey share, there are actions underway right now that are having positive effect. Enacting national legislation, as we've seen, can have a profound, far-reaching positive effect and move us toward, as Senator Kaine recommends, an affirmative solicitation of the well-being of our healthcare workforce, one that recognizes being a healer is hard on the spirit and soul, and that at the system level, we've built that into protecting our healthcare workforce. In parallel with developing the first ever national legislation, the Dr. Lorna Breen Foundation has partnered with First Responders First and the Johnson & Johnson Center for Health Worker Innovation to launch the All-In campaign, which provides financial and practical support to healthcare organizations implementing and scaling promising workforce well-being solutions and practices. To learn more and accelerate these much-needed actions and resources, check out allinforhealthcare.org. Let me echo Chris's closing comments. You are not alone. We're listening and we care. If you or someone you know is in crisis, please text 988. There's someone available 24/7 and it's confidential. And maybe you add this to your phone's contact list so it's there just in case. For See You Now, I'm Shauna Butler, and we're here for you.
Nurses are transforming healthcare through innovation, compassion, and leadership. And Johnson & Johnson is proud to continue its 125-year commitment to champion nurses through recognition, skill building, leadership development, and more. The American Nurses Association is dedicated to building a culture of innovation. Nurses improve the lives of patients and communities through innovative thinking, empathetic connection, scientific rigor, and sheer determination. ANA is proud to support and advocate for our nation's most valuable healthcare resource, our nurses. For more information on See You Now and to listen to any of the earlier episodes in our library, visit seeyounowpodcast.com.